So my name's Andrew Campbell. I'm an audiologist. I've been doing this kind of work for 24 years. During that period, I've treated over 5,000 patients, and my passion is in patient education. So I guess in all this time of doing this kind of work and treating all those patients, I've found a pretty clear trend is that those that my patients that have taken an interest in sessions like this and in my books, they just I just tend to find that the better educated our patients are, the better they tend to do with treatment. So I'm sure you'll find this session really worthwhile. But in my 24 years of doing this work as an audiologist, there hasn't been a week that's gone by where I've not come across the heartbreaking case of someone that's just simply left treating their hearing loss too late. So we know that most people here in Australia with a treatable hearing problem, they never ever set foot in an audiologist's office. In fact, only about a third of people that could benefit from having their hearing loss treated ever take any form of action. We also know that on average there's a 10-year delay from the point where people could benefit from having their hearing loss to that point where they actually go and take action. And what the science is telling us, and we're going to be sharing quite a bit of science with you this afternoon, is that that's absolutely 10 years too late. And I can tell you from a practical point of view, doing this work for a long, long time, is that we just get our best results in the hearing clinic when we catch hearing loss early and we treat it early. So we're going to be talking a bit about the treatment of hearing loss. And for the most common forms of hearing loss, the most effective and appropriate treatment for that is, in fact, hearing aids, or we like to call them hearing devices. I should mention that this session's not about trying to ram hearing aids down your throat or anything like that. It's hopefully to have you leave this session with just at least a bit of a sense of just how your hearing health relates to your brain health. So particularly over the past 10 years, people like me and our other audiologists have become to understand this topic in a whole lot more detail. But it's not at the point where we consider it really to be common knowledge. In fact, there was a recent survey done of the Australian public just trying to get a sense of just how well Australians understand that there are links between their hearing health and their brain health. And what they found was that 84% of Australians had absolutely no idea that there was any links between their hearing health and their brain health. So hopefully you'll leave this session with just at least a bit of a clue as to what's going on there. So I'm just going to share my screen and see if I can access a bit of a PowerPoint presentation to take you through the session here. So essentially, it's all coming up there. There we go. So when we're thinking about the links between hearing loss and dementia risk, and in terms of when that really started to appear in the medical literature, that started to appear from about the 1980s, and it was with a particular reference to chronic social isolation. So from around the 1980s, the there was mentions in the medical literature that there was signs that people that had increasing levels of hearing loss were increasingly at risk of being chronically socially isolated, which may contribute to a dementia risk. But it really wasn't until 2011 when really for the first time hearing was involved in a major multi-million dollar study of the aging process. So in this particular research, there were 600 people in the study, all aged around the age of 60. Couple of important points to make. This was a general study of aging. They weren't just looking at hearing, they were looking at all sorts of things known to be associated with aging: coronary heart disease, diabetes, cancer, male pattern baldness, arthritis. Hearing was just a very small part of what they were looking at. Another important point to make: to be part of this important research, the participants couldn't have had a history of having dementia. So they were coming into this research without a dementia diagnosis. So every year they came into the lab. So 600 people aged around the age of 60. This was done over a 12-year period. And every year over that 12-year period, they came into the lab for intensive testing, looking at all sorts of things known to be associated with aging. So huge amounts of data put together over that 12-year period. And once all the analysis was done, the most stunning surprisings that came out were those relating to hearing loss and dementia risk. What they found was that those people that had a mild hearing loss, so a mild hearing loss, it's about a 25% hearing loss. When I graduated from university 24 years ago, we didn't really care so much about a mild hearing loss, but given what we now know, we're most certainly concerned about it. Those people in the study that had a mild hearing loss, they were twice as likely to have developed dementia over that 12-year period compared to their peers that had normal hearing. Those with a moderate hearing loss, so a moderate hearing loss, it's about a 25 to 40% hearing loss. In across our network of clinics in Queensland, Sydney, and Melbourne, most of our patients, if we think about the most common severity of hearing loss, it's moderate hearing loss is the one that we deal with the most. And so those people that had a moderate hearing loss in the study, they were 3 times more likely to have developed dementia over that 12-year period compared to their peers that had normal hearing. And those with a severe hearing loss, so a severe hearing loss, it's about a 50% or more hearing loss. Those same people I mentioned at the very beginning that really had put off doing something about their hearing loss, really to the point where it was too late for us audiologists to get a really optimal outcome in the hearing clinic. They were 5 times more likely to have developed dementia over that 12-year period compared to their peers that had normal hearing. So these findings, they created quite a stir in the medical community, a lot of media attention, particularly in the United States. So front cover of the New York Times, Today Show, and things like that. Not a whole lot of media attention here in Australia, but I'd have to say that slowly but surely, particularly in the medical community, there is a growing awareness of these links between our hearing health and our brain health. The important thing an important point to make about this study was that I don't want really anyone to be thinking that, if you're experiencing some degree of hearing loss, then it's a foregone conclusion that you're going to experience cognitive decline. That's not what I'm saying. Basically, the significance of this study is that it was for the very first time that this link between hearing loss and dementia risk was quantified and observed and in a very high quality study. And it was the first time that it was kind of, that they were able to put some numbers around it. And what it did is it really sparked a whole lot of research interest into this area. So since this study was published, there's been no less than 50 additional studies that have looked at the links between hearing loss and the risk of cognitive decline, and also what can we actually do about it? So what are the impacts of treatment? But in terms of I guess, some broader statistics that kind of keep coming up, are that hearing loss is associated with an acceleration of cognitive decline by 30 to 40%. And for every 25% of hearing loss, or like 25 decibels of hearing loss, which is roughly 25% of hearing loss, for every 25% of hearing loss, there's a 6.8-year premature aging of our cognitive abilities. So when I'm talking about cognitive abilities, I'm talking about things like short-term memory, processing speed, reaction times, what we call our general executive functions, all of which are capacities that we need to live day-to-day life independently. What the research is telling us is that having a hearing loss prematurely ages these capacities. So an important point to make about that's a 6.8-year premature aging of cognitive abilities is that exact same figure has come up in no less than 4 studies. So we consider this premature aging of cognitive abilities to be kind of a rather robust phenomena. I had the pleasure of meeting Professor Frank Lin, who is the head researcher behind that study, and his team have, after that study was published, he's been over in Sydney a couple of times for some intensive training, which I've been fortunate enough to be a part of, and also his team have they subsequently secured the most amount of funding that I've seen in any audiology research project, not just to look at the impacts of hearing loss on cognitive decline, but what can we actually do about it? What are the impacts of treatment? And I'll be sharing just briefly some of his findings just a little bit later on. But when thinking about the links between hearing loss and cognitive decline, Professor Lin's team, they've really identified three main mechanisms at play. I've mentioned one of them already, and that is social isolation. So we've known for decades that the more hearing loss that someone has, the more at risk they are at becoming chronically socially isolated. And it tends to start with the most common complaint that we hear all day, every day in the hearing clinic, and that is difficulty hearing in background noise and group situations. So most of my patients, they're able to hear me quite okay in the one-on-one and quiet of the hearing clinic. But as soon as they get out to that family gathering, that cocktail party, that noisy, echoey restaurant or cafe, that's where a lot of the difficulties begin. It starts to become potentially embarrassing to be in these environments, missing the punchline of a joke, laughing at something that really wasn't meant to be a joke. People start to feel this increasing sense of being isolated or separated from the interaction, not directly involved. None of that is enjoyable. So there becomes a point in time where people either consciously or subconsciously start to avoid those situations. And that's the point where we really do start to get concerned about it. Um, the second set of factors relates to brain overload, or we like to call it cognitive overload. So for the most common forms of hearing loss, it's not like people are hearing no words. More often than not, like around 90% of the time, at least with my patients, they're able to hear all of the A, E, I, O, U vowels, but not all of the softer, higher pitched consonant sounds, which are typically the beginnings and ends of words. Problem is, if we're not hearing all of the consonant sounds, because the consonants they carry most of the meanings of words. So if we're not hearing all of the consonant sounds, in order to communicate, we need to get that information from somewhere else, most commonly from our vision. Body language, facial expressions, movement on lips, they all give us clues as to what that person might be talking about. Now, often that's not going to be enough, and it's going to be helpful for us to think of the context of the conversation. So if we know the context and we can get the gist, hopefully we've got enough information to put that communication puzzle together. The problem is it's quite hard work. Ask anyone that has a significant hearing loss what it's like for them at the end of the day interacting with groups of different people in challenging environments. And they'll tell you that that process can actually be quite exhausting. It really is quite hard work. And what that hearing loss is doing is presenting a consistent 24/7 load onto our finite cognitive resources. Third set of considerations relates to cerebral atrophy, which is the medical terminology for brain shrinkage. So for the most common forms of hearing loss, we can actually see up to a 40% reduction in the volume of the size or parts of the brain associated with speech, hearing, language, and memory when we've got a hearing loss that we've done nothing about. So the links between hearing loss and memory loss are starting to become better understood. There was a study published last year that looked at the hippocampus, so this really important structure for memory in the brain. Part of the role of the hippocampus is to convert short-term memories into long-term memories. The researchers were able to actually reliably predict how much the hippocampus, so this important structure for converting short-term memories into long-term memories, had degraded as a result of how much hearing loss that person had. So what we're seeing in the literature are clear links between our hearing abilities and our memory abilities to the point where we're able to observe, I guess, evidence that there are unique and independent pathways between our hearing abilities and our memory abilities. We can also start to see some disorganization effects occurring when we've got a hearing loss that we've done nothing about. And I've got some visuals that I'll show you shortly just to illustrate that. Um, so this is just one example of a single gentleman who has cerebral atrophy in one ear. So he's got uh, normal hearing in one ear and a severe hearing loss in the other ear. You can see, so the little arrows here just above the normal hearing side, you can see above that white arrow, there's the brain volume there relative to the other side above the red arrow, and that's a severely impacted side. And as you can see, there's relatively less volume in that area. I had I was invited to give this seminar in person in the south side of Brisbane. Must be close to a year now ago, and one of the gentlemen in the audience yelled out, "I reckon this bloke listens to Sky News in one ear and the ABC in the other." Uh, the thing is, it's not all doom and gloom. The good news is that when we can catch hearing loss in time and provide the correct treatment to it, we can in fact see a reversal of a number of these downstream trends. So this particular study looked at the average of, looked at 20, 26 people in this study and looked at the average of their brains when they were scanned under different conditions. And the important point to make about this study, what was really interesting, is that the people in this study, they had a mild hearing loss, so the kind that we never used to care about. As the researchers described it, even at mild levels of hearing loss, they're able to observe evidence of what they describe as some vacant real estate starting to emerge in the hearing centers in the brain, even at mild levels of hearing loss, of which the visual centers appear to be encroaching upon. Um, so how they were able to demonstrate that was by flashing visual stimulation into the eyes of these people that had a mild hearing loss. And that visual stimulation was showing up in the hearing centers in the brain, just around about where I've got my cursor there. It really shouldn't be there, and it's good evidence that even at mild levels of hearing loss, that the hearing centers in the brain can start to become disorganized. They thought, well, gee, maybe these people are getting better at lip reading, and found that they were no better at lip reading than people that had normal hearing. Then they put them through a range of cognitive tests and found that they performed significantly worse on a range of cognitive tests relative to people that had normal hearing. Then they put them through a range of tests for hearing in background noise and groups and found that they performed significantly worse for tests for hearing in background noise and groups compared to those that had normal hearing. So the people in this study, they received what I like to call the three legs of the stool, and that is good quality and appropriate for them hearing devices, fitted using best practices, which should always be used in audiology that we know aren't always used. And most importantly, the people in this study, they wore their devices for at least 12 hours per day. Now, the thing is, what we know about hearing devices, and it's a particular issue that we have right here in Australia. So we know that most people with hearing aids, we like to call them hearing devices, but most people with hearing aids here in Australia, um, we know they either don't wear them or they don't wear them enough. So we know that, how often people are wearing the hearing aids because they've got these teeny tiny little databases on them, and we actually like to check. There was a major study done of 15,000 hearing device owners, and what they found that a third of the people in the study, they really weren't wearing those devices at all. They were in the bathroom cabinet, they were in the top drawer. Some people in the study were actually wearing them in their pocket, really anywhere where they were designed to be. Another third of the people in the study are what I like to call my reading glass wearers. So they'll pop the devices on maybe to come to, a session like this, maybe to catch up with family and friends. Most of the time they're not wearing the devices. Only a third of the people in the study actually wore them as they should, which is at least 12 hours per day. So if you've got hearing devices, if someday you need them or you know someone that has them or needs them, the best possible advice that any audiologist can give you is that those devices really need to be in for at least 12 hours a day to get the benefit and value. And I can tell you from a practical point of view, doing this work for a long, long time, is that we just get our best results in the hearing clinic when those devices, I mean, the difference between someone who keeps those devices in 12 hours a day versus someone who treats them kind of like their reading glasses, it really is like chalk and cheese. So what we find really is that the more the better. I was invited to do a panel discussion at a recent conference that we had. That was our national conference for our professional body, is held in Adelaide, and essentially the one of the professors there from the University of Melbourne was there. She was presenting some of her research about improvements what they see in cognitive function in people that wore hearing aids. And essentially what they've found is that they see consistent improvements in cognitive function as a result of really consistent hearing device use. But they've found that there's actually a dose dependency to that, really meaning the more the better. So the more those devices are in, essentially the better people tend to do, to the point where they've found that if people own hearing devices and they wear them for 6.5 hours a day or less, they may get some practical benefit, but it doesn't really move the needle on cognitive function. There was another study that was published that looked at three groups of people. So it was done over 10 years, 10,000 people in the study, three different groups. One group in the study had hearing loss, done nothing about it. So what we call untreated hearing loss. Another group in the study, they, uh, they had hearing devices that actually wore them for 12 hours a day. And then there was a third group in the study that owned hearing devices, wore them on occasion, kind of treated them like reading glasses. And what they were looking at in this study was all-cause mortality. So for the risk of dying for whatever reason over that 12-year period. What they found was that those people that owned hearing devices and wore them at least 12 hours per day, their risk of dying for whatever reason was 24% less than those that had hearing loss and did nothing about it. So there's a 24% lower risk of all-cause mortality, risk of dying for whatever reason in people that had that wore hearing aids consistently. Uh, the thing is though, those that wore devices and only wore them on occasion, there wasn't any life expectancy benefit. So their risk of all-cause mortality, they were no better off than those that didn't wear them at all. So there's, when hearing devices are warranted, there's something to be said for consistent hearing device use. So that's what these people got. They got the three legs of the stool, which are good quality devices fitted using best practices. They weren't and they actually kept them in for at least 10 hours per day in this study. Then after 6 months, they came back into the lab, had their brain scanned again, did all the tests. And essentially, what they found was when they flashed visual stimulation into the eyes of these people, that it had actually got out of the hearing centers in the brain and it was showing up just in the visual centers in the brain, which is good evidence that as a result of receiving proper stimulation for their hearing loss, that their brains actually got into better shape. So those parts of the brain that should be performing specific functions, processing visual information, were actually doing their job more directly, and that visual stimulation wasn't showing up in the hearing centers in the brain. These people perform significantly better for tests for hearing and background noise in groups, and they perform significantly better on a range of cognitive tests. I had the pleasure actually of going over to Texas for an intensive conference on hearing and brain health, and the head researcher behind this study. This was I went there last year. Dr. Hannah Glick, she was a head researcher behind this study. She was there and was able to explain these results in a whole lot of detail. Basically, what they thought was that, gee, we're getting these really elegant results in the lab. What happens if we go out in the community, find 100 people out there that just so happen to be wearing hearing aids? Let's bring them into the lab, do all the tests, let's see what we find. Basically, what they found was that for 40% of the people out in the community wearing hearing aids, they were getting these nice, elegant results, brains in really good shape, doing really well on all the tests. However, for 60% of the people out there in the community wearing hearing aids, their brains look like they hadn't worn a device for a day in their whole life. On closer examination, what the researchers found was that the majority of these people were underfit, basically meaning that their devices weren't set up using established best practices that we should always be using when we're setting up hearing aids. And I've got to say, I see this happening in my clinic all the time, and my clinicians in Melbourne and Victoria see this all the time. We estimate that around about 60% of the time, because we do a lot of hearing aid fix-up work, that is people that have been fitted with hearing devices at other clinics that, for whatever reason, are not particularly happy with how things are going. They come and see us hoping that we'll, get things better on track for them. And most of the time, like about 60% of the time, it's not the devices that are the issue. It's usually because they're not actually set up properly. They're not set up using best practices. There's kind of two ways in which we can set hearing devices up. One is the right way, where we go through an objective process. We call it real ear insertion gain, where we pop a little microphone in the ear canal and we tune the devices up against a hearing loss prescription. And that way we can be confident that the devices are doing exactly what they should be doing. Or there's the other way, which we see evidence of happening lots of the time, where the devices are just set up using a computer estimate, which is always just way off, the mark. Um, so the underutilization of best practices, it's an issue here in Australia. It's an issue over in the United States. But the issue of people that own hearing devices that don't wear them enough, that's a uniquely Australian issue. This is something that's been studied worldwide of people that own hearing devices in different countries, how often do they actually wear them. And in the United States, of people that, for example, in the United States, of people that own hearing devices, um, those that actually, on average, they wear them for 10.8 hours per day, which is actually pretty good. If we're shooting for 12, 10.8 hours per day is pretty good. Here in Australia, that it's only 6.8 hours per day. So, and of the countries where this has been measured, and there's been quite a few countries where, this has been looked at, Australia actually performs the lowest. So, if there were such a thing as a gold medal for the country who owns hearing devices that wears them the least, then Australia gets the gold medal. I've been fortunate in that I've worked in 5 different countries in my profession. So it's given me, I guess, a bit of a view as to, what works well in other countries, what do we do well in Australia, what could we do better. One thing that I'd tell you, though, that's unique about the hearing profession here in Australia is that we have the most corporatized expression of audiology that we really see anywhere in the world. So most of the clinics out there, and don't get me wrong, the manufacturer, like these corporate clinics, I'm sure that the people that work there are I'm sure they're the loveliest people with their hearts in the right places. But here in Australia, most of the clinics, like 93% of them, are owned by overseas-based corporate entities, and the majority of those are hearing device manufacturers. Um, Now, in the United States, of people that of the hearing clinics there, 66% of them, or two-thirds of them, are what we call independent clinics, meaning that they're run and owned by a hearing professional like me. The independent clinic has access to all of the solutions that are out there. Um, Whereas and I've also found that independent clinics are more likely to engage in the best practices that are going to get you the results. Here in Australia, only 7% of the clinics are independent, meaning they're run and owned by a hearing professional like me, have access to all of the solutions that are out there, and are more likely to engage in the best practices that will get you the results. Our primary concern about manufacturer-owned clinics, and which is actually most of them, is that when you go to one of these clinics, you can have any hearing aid that you like, as long as it's the specific type that they make. There's lots of aid manufacturers, they've all pros and cons, and not one of them has the right solution for the right hearing loss for the right person every single time. And even when they do, what we're finding is that with the rapid increases in technological advancement, what might be the ideal solution today may not be the ideal solution in 3 months or 6 months' time. Unless you see someone that's independent, they're not going to have access to all those solutions. So I'm not saying you have to come to our clinics or anything like that. My best advice, though, to anyone that's looking to improve upon their hearing situation is to seek out a good independent audiologist. They're not going to be restricted by choice. and they're more likely to engage in the best practices that are going to get you the results. Uh, Now, I mentioned a little bit earlier that that myself and my two other colleagues, Denver Joseph and Reese Cooper, we've recently written a book called The Power of Sound. Um, this is really up to date. My previous book that I published, Hearing and Brain Health, there's at least 30,000 of copies of that out in the community. We saw that there's just a lot of really important recent research coming out. So, and in addition to that, there's a program that I'll talk to you a little bit later on. It's called Lace AI Pro, and it's a really innovative program that utilizes some artificial intelligence to gradually strengthen our ability to hear well in background noise and group situations. So we're finding that our patients that engage in that program are just getting much more value and benefit from their devices. I'm going to tell you a little bit more about that program just a little bit later on. But as a thank you and appreciation for you joining this call, we're going to make the Power of Sound, our new book, available to you completely free of charge. So there's on the next slide here, there's a QR code. If you are in a position to take a copy of that or to snap that with your phone, that will lead you to just a little feedback form that we have. There's just a few questions. It's really helpful to get some feedback on how our seminars are going. Uh, you will have the opportunity to order a copy of The Power of Sound, our latest book. And there are some information requests. So I've mentioned Lace AI Pro. I'll talk about that a little bit later on. It's basically a program to help you hear better in background noise and groups. Um, Tinnitus or ringing in the ears is a really common issue for a lot of our patients. So I don't have time to go into the absolute detail about tinnitus in this session. However, what we have done is put together a comprehensive resource file to help guide patients with tinnitus. If that's a to you, just if you can access the QR code on the screen there, and that'll lead you to that survey. And another thing that I'll just mention it now that we offer anyone that has taken the time to join our webinar this evening. We offer a complimentary consultation at one of our practices. I'll give you the addresses a bit. So we are in going from north to south. We're at Ashgrove in Brisbane, Southport on the Gold Coast, a clinic at Wahroonga in Sydney, and also a clinic on Macquarie Street in Sydney CBD. And we also have a clinic in Hawthorn East in Melbourne. So I often ask this question at my live seminars, what is the most common cause of hearing loss? And the most common cause of hearing loss, I mean, most people would tend to think that it's quite possibly due to noise, be it loud music, industrial noise, and so on. It is, in fact, the most common cause of hearing loss is, in fact, aging. So age-related hearing loss, we call it presbycusis. It's really common. Why is it really common? Because age-related hearing loss, it will in fact happen to really anyone that lives long enough. Um, the second leading cause of hearing loss is overexposure to noise. So be it industrial noise, loud music, and so on. Third leading cause of hearing loss is genetic factors. So there are some specific diseases like Meniere's disease, otosclerosis that can lead to hearing loss. We can just simply have hearing loss running in the family. But I should mention that either age-related hearing loss or noise-induced hearing loss, there's actually quite a strong genetic component to both of those. Very occasionally, I'll meet someone who would like to blame someone for their hearing loss. And to those people, I say, well, there's likely two people you can blame, and they're called your parents. I'm guessing many of you would have had your hearing tests before. If you have, you might be familiar with this graph I've got up on the screen. If you haven't, I'll just give you a really, really quick overview. Essentially, I'm just running my cursor right over the top. If your hearing is absolutely completely normal, then your hearing's going to be right along the top there like that. Test the low pitch sounds this end, high pitches this end, and the further down we need to go, louder the sounds need to be for you to hear them. We represent the right ear with the circles and the left ear with the crosses. In the low pitches, you can see with this person, their hearing is, well, the minimum hearing levels there is toward the top, meaning that these parts of hearing are in relatively better shape than the high pitches, which are sloping down, as you can see in that we call them the high frequencies. So this is a really common configuration of hearing loss that we see all day, every day in the hearing clinic. And someone with a hearing profile like this, now we're always going to be primarily focused on speech understanding. So someone with a profile like this, they're going to be able to hear all of the A, E, I, O, U vowels. They're not going to be able to hear all of the softer, higher pitched consonant sounds, which are frequently the beginnings and ends of words. So someone with this kind of hearing loss, they're not going to be able to hear all of the sounds within this light blue area there, which, a lot of the consonants are appearing there, so they're not going to be able to hear those. They will, however, be able to hear the A, E, I, O, U vowels. Now, when we're not hearing all the vowels, what we're needing to do is supplement those bits that we can hear with visual cues, body language, facial expressions, movement on lips. Often that's not going to be enough. It's going to be helpful for us to think of the context of the conversation. So hopefully we've got enough information to put that together. Some people I see are a bit confused as to whether they've got a hearing loss or not, because they're able to, because when you're hearing just the vowels, you know that someone's talking, you're getting that perception of volume and loudness. What you won't be getting, however, is the volume is the clarity. So you'll know someone's talking, but just getting the clarity and the meaning of what they're saying starts to become an increasing challenge. And that puts a consistent 24/7 load onto our finite cognitive resources. Now, I'm just going to talk through the topic of dementia now. So dementia, uh, particularly in this context, I just want to talk about it in, how can this start to become related to our hearing abilities? So one of the ways in which someone might be diagnosed as having dementia or not is via the significant presence of at least two of the issues I've got right up on the screen. Um, and these are listed in order of significance and importance. So right up in the very top, you might have predicted that memory loss. It's a rather fundamental consideration when we're considering whether someone has whether someone has dementia or not. So in relation to our hearing, I mean, we've known for decades that the more hearing loss that someone has, and the more they're needing to put into following conversation, then the less of that conversation they're inclined to remember. I mentioned a little earlier about that study that showed the hippocampus, that important memory structure in the brain for converting short-term memories into long-term memories. What the researchers found was, if you remember that audiogram, that slide that showed the graph with the hearing going down, basically the further down on that graph the participants in the study were, the more likely that hippocampus, that important structure for memory in the brain, had become degraded. And if we're thinking about our short-term memory, so short-term memory for most people, we can fit up to 7 bits of information at any one time into our short-term memory. You might recall when home phone numbers were 7 digits long, they were so much easier to remember than, say, a mobile phone number. So 7 bits of information, it really isn't a whole lot. Particularly if we're following conversation in a background noise or a group situation, we're needing to extract those bits that we can hear, put together with the bits that we can hear, the bits that we can see, that all goes into short-term memory as well. Often that's not going to be enough when we think of the context of the conversation. If we know the context and we can get the gist, then hopefully we've got enough information to put that communication puzzle together. The problem is it's actually quite hard work. Um, and it puts a consistent load onto our finite capacity of short-term memory. So, we've got this flowing conversation, we're trying to put in auditory or hearing information, visual information, even context information in a flowing conversation. It doesn't take a whole lot for our short-term memory to really start to saturate. What we know about short-term memory is that the more saturated it becomes, the less resource there is for encoding into long-term memory. So we're seeing hopefully starting to get a bit of a sense of just how well how our memory abilities can relate to our hearing abilities. Next on the list is communication difficulties. So the primary concern in relation to brain health with communication difficulties is, and I should mention that age-related hearing loss is the most common cause of communication difficulties. So I guess that the primary concern about communication difficulties is that they put us at risk for chronic social isolation. And, sometimes I get a bit of pushback when uh, talking about social isolation. Uh, some people say, oh, you're just talking in pubs. You know, I'm not interested in parties and pubs, so, that doesn't really apply to me. Um, well, not always obvious is that it start to become a bit isolating on the domestic front. As the hearing goes down, then things like throwaway lines, humor, which loses all effect if you're needing to repeat yourself, subtleties, the richness of communication, even intimate communication, just starts to become more challenging the more hearing loss that we have, which, becomes isolating not just for the person that has hearing loss, but potentially isolating for anyone that's interested in a rich, nuanced dialogue with that person. And there have been a number of studies that have looked at detrimental health impacts of the partners of hearing impaired. So looking at physical health, psychological health, and social health. One such study showed significant reductions in those all three areas of physical, psychological, and social health over a 5-year period. And the variable in the study was, did your partner have a hearing loss or not? So those people that had partners with hearing impairment, it tend to affect. You can understand how it would affect at least social health. So as we go down, the next item on the list, attention deficits. So what we know about hearing loss is that it impacts on our ability to focus attention, sustain attention, to divide attention. The other two issues down the list, reasoning and judgment issues, visual perception challenges, not so related to our ability to hear well, but the top three criteria are. So hopefully you're starting to get a bit of a sense as to, okay, well, just how our hearing abilities can relate to such cognitive abilities. So dementia prevention has actually become quite a hot topic. Uh, Last year in 2024, dementia became the leading cause of death for Australians, followed by coronary heart disease. So, and also over the past 10 years, dementia-related death has actually increased in Australia by 68%, and has actually decreased by coronary heart disease by 19%. So it would appear that the medical community become much better at treating different parts of the body. But when it comes to our brain health, we don't really have effective pharmaceutical treatment for cognitive decline. What we do have, however, is the potential for prevention. So the Lancet Journal, who are the most prestigious medical journal on the planet, well, arguably, for brain health, they've done three major reviews looking at, well, what does the world's best research tell us about dementia prevention? And essentially, they've come up with a list of the top 12 things that we can do to help reduce our dementia risk. All in all, they currently estimate that up to 45% of cases of dementia could be prevented through long-term lifestyle modification. And they've essentially come up with a list of these top 12 things that we can do to help reduce our dementia risk. Second on the list is less education. So again, for all you people on this call, of the 101 other things you could be doing right now, you've decided to take time out of your day and join an educational session. And what I'd encourage you to do is to do what you can to establish a habit of lifelong learning, because it really is one of the best things that you can do for your brain health. Right up on the top of the list is, in fact, hearing loss. Each of the times that the Lancet Journal has done these major reviews looking at, well, what does the world's best research tell us about dementia prevention? Hearing loss is always at the top of the list. Why is hearing loss always at the top of the list? Well, we know that hearing loss is really common. It's going to happen to really anyone that lives long enough. We know that the impacts of hearing loss on brain health can be devastating. And we also know that hearing loss is highly treatable, provided it's the right treatment, provided it's fitted correctly, and provided that it's worn consistently. Uh, as we go down the list, there are a couple of other factors worth mentioning. So we go hearing loss, less education, smoking, not so relevant. But the next two are, so depression, and we've spoken a bit about social isolation already, but just like social isolation, with depression, the more hearing loss that someone has, the more at risk they are at becoming chronically depressed. Further down the list, there's a mention of physical inactivity. Again, that's something we know about people that have hearing loss. They tend to be less physically active than those that have better hearing. We think it's likely because they're less inclined to socialize and get out of the house as much as people with better hearing. So, if we look at, well, what does the world's best research tell us about the best things that we can do to reduce our dementia risk? Uh, those factors that either directly relate to our ability to hear well or indirectly can be associated with hearing. More than half of the things that we can do to reduce our dementia risk relates in some way for our ability to hear well. And if we're serious about developing a habit of lifelong learning, then being able to attend lectures, Zoom sessions like this, workshops, group interactions, not to mention the cognitive reserve to be able to focus attention, sustain attention, divide attention, and also to retain that new information that we're learning. So if we're serious about establish that habit, addressing hearing loss can really help with that too. I mentioned a bit earlier that study that Professor Frank Lin sourced $40 million for. Essentially, what they did in this study, there was 1,000 people, half of them got hearing aids, half of them didn't. And this is an ongoing study. It's going to be going for at least 7 years. They did a 3-year check-in just to see how people were going. And basically, within that period, they found that in older adults that were at risk for cognitive decline, hearing intervention, so consistent use of hearing devices, slowed down loss of thinking and memory by 48% over a 3-year period, which is absolutely massive in the context of a condition where we really don't have effective medications for. Now, if I were able to ask you, um, if you've got hearing devices, and if you've got hearing devices, if you're totally satisfied with how they're working in social and background noise environments, if you're totally satisfied with that, you would be in the minority. So what we know is that that it's a pretty persistent area of dissatisfaction with hearing devices. And fortunately, we're at a point where we've got some methodology to help with really improving upon that. The hearing devices themselves have improved in their ability to give priority to speech over background noise. However, when you're in situations like uh, cafes, restaurants, group situations where the noise is other people's voices, that's where some targeted cognitive training can help. Because we can only really expect hearing devices to perform a pretty basic function. They enable us to hear sounds, but they don't necessarily enable us to really focus on exactly who we're wanting to hear in a noisy environment and be able to really comprehend what they're saying. The good news is that we can actually we're in a position now where we've got tools where we can really provide targeted training to those really important functions. Um, so the concept of auditory training has been around for quite a long time. Um, in fact, if we look at any of the professional bodies internationally in our field about, what is the gold standard of treating hearing loss, and they'll tell you that that auditory training, if we're serious about getting the best results, we should be doing some form of auditory training with our patients that wear hearing devices. The problem is it's been actually quite a challenging thing and a bit of an impractical thing to deliver up until recently. So we used to be the case that we'd need to bring people in for dozens of appointments. Not always convenient. The cost, kind of adds up. I know people try to do it on Zoom. Again, it's time consuming and costly. Um, there's a program called LACE that stands for Listening Communication Enhancement that's been around for about 20 years. And even to deliver that was a challenge. It was done by CD-ROM and, there's a chunky kind of website, all in an American accent, all a little bit boring. However, the makers of that program have done a huge amount of research. There's been at least 80 papers on it, on the program, and it's a really robust way of gradually strengthening our ability to hear better in background noise in groups. And essentially, with this kind of training, what we're seeing is if you can stick with it for a month or two, we're seeing people that are getting improvements in their ability to understand speech in noise by between 30 to 60%, which is a noticeable improvement if you can just kind of stick with this kind of training. So the program now is called Lace AI Pro. Basically, they've poured millions of dollars into it to make it really accessible. Probably the easiest way is via a mobile phone. You can do it on any computer or tablet. It's only available through hearing clinics. It's a program that's widely used in the United States and the United Kingdom. To my understanding, we're the only provider in Australia that has it at the moment. I'm sure more will in future. We hounded them to make it available in an Australian accent to make it more user-friendly and relevant to our patients. And basically, what it does is in less than 15 minutes a day, it gradually strengthens your ability to separate speech from noise. That's the backbone of the program. So there's really 5 different ways in which LACE works. One is so speech and noise, strengthening your ability to separate speech from noise, rapid speech, improving on your ability to understand people that talk really fast, working memory, so helping to improve upon the capacity of your short-term memory. I mentioned a few times in this session that uh, you know, having hearing loss can impact short-term memory, and in terms of when we're compensating for hearing loss with visual and context cues, that puts a consistent load onto our short-term memory. So the better capacity that we have in our short-term, or we can call it our working memory, then the more likely we're going to retain those things that we're learning, and also, short-term memory is helpful for a whole lot of other things in addition to hearing in background noise. Another part of the program, missing words, strengthens your ability to follow conversations when you haven't heard every word in full. And soon to be added to the program is a visual integration, which helps to sharpen your ability to lip read. Um, so we do see people that, so it's become a standard thing that we offer in our practice. Essentially, anyone that gets fitted with hearing devices, we make that a prescribed part of the treatment. Occasionally, we see people that have some hearing loss, but they're not at the point where really hearing aids are warranted. That can help too. Or people that have hearing aids already and would like to do better for hearing and background noise, that program can help also. Um, so at the very end of this presentation, there'll be a link to give us a bit of feedback about how this session has gone and express interest in that program. Um, and so we do actually make it available at a reduced rate for people that have taken the time to uh, join our sessions. We prefer to do that following a consultation in our clinics. We'll get to that in a moment. But you can this is a kind of program you can't just go to the App Store and get it. It needs to be prescribed by a hearing clinic. But it really has changed the way we work, and we're finding that we're getting um, just better results with our patients. We're, it's probably the best thing that's happened, I think, to the profession this year. So I mentioned earlier, I'm just kind of wrapping up now. I mentioned the three legs of the stool, which, to treat hearing loss properly, you know, good quality devices, fitted using best practices, worn at least 12 hours a day. Now we've got the fourth leg of the stool, supported by cognitive training. We find that people just tend to do better when they can engage in that. By analogy, for a stool to work, you don't need to have a backrest. But what we tend to find is that, particularly for the initial consultation with us, we find that things generally go a lot more smoothly if we have a frequent communication partner at the initial assessment. Uh, in essence, we're dealing with a communication disorder, and it can really be helpful to understand, well, where is communication breaking down, how that's being dealt with, because it just gives us a lot more information, and uh, essentially gives more nuance, and we're able to do our jobs better when we're understanding the impact of communication, not just, how hearing loss is showing up on a graph. And just to mention there of patient education, I mentioned at the very start, the reason why we do these sessions is because what we've found is that time and time again, the better educated our patients are about why all this is important and how to get the best results from treatment, the better they tend to do. So we can think of that in another way, and we kind of articulate this in our new book, The Power of Sound, that we see like treating hearing loss and really getting the best results from treatment is it's kind of like you can think of an iceberg where the device is the visible, tangible, kind of 20%, the bit that pokes out of the water. However, what's underneath and supports that device by analogy is the 80% that sits underneath. So that's the 80% of the human factors that make that get the most out of the device and makes that treatment process the most successful. Starting with making sure those devices are fitted properly. Uh, that's kind of on us. It's on our patients to wear them consistently, ideally 12 hours a day, to engage in that routine cognitive training. Helpful, if possible, to have a partner involved. A frequent communication partner tends to help smooth the process out, make things run better. And when our patients engage in educational sessions like this and in our books, we find that they just tend to do way better with treatment. Um, so I'd like to leave you with a final take-home statement shortly, but I'll just mention where our clinics are. We're at Ashgrove in and Southport in Queensland. We've got a talented audiologist, Reese Cooper, that works up there. I am based in Sydney, mainly in the CBD. I've also got a clinic in Wahroonga, which is near Hornsby, and we've got another clinic full-time clinic with a very talented audiologist, also Denver Joseph down in Hawthorne East. If you didn't get that QR code before, uh, I've got it up on the screen again. And if you're not in a position to, if you're watching this on your phone or you're not able to take that QR code, there will be a link at the very end of the presentation for you to give us a bit of feedback, uh, order a complimentary copy of The Power of Sound, which is the book that I've co-written with our other two audiologists, uh, Denver and Reese. Uh, I've mentioned Lace AI Pro and Tinnitus Pro. Uh, they're both aspects that you can request further information on. And also one thing that we offer to anyone who has taken time out of their schedule to join us for a session like this is a complimentary consultation with our audiologists in our respective clinics. So, Reese is up in Queensland, I'm in Sydney, Denver is in Melbourne. If you've not had your hearing assessed, or you have, and you'd like to, I guess, uh, have us as independent audiologists give you, I guess, the best advice that we can. Highly recommend that you make that request. Essentially, what we like to do, and that's for an in-person appointment, as well as what we like to do ahead of our in-person appointments, are it's a complimentary telehealth consultation where we give you a quick phone call. So we schedule a time for that, get to understand your situation a bit better, and what to expect in the clinic, how to find us, and so on. Just gives us a bit of background and helps make that next step a bit smoother. And so both of those, the in-person appointment with us and the telehealth appointment, that's something that we offer totally complimentary. So if you weren't able to take that QR code, just wait around to the end, and there'll be you can do a little survey there, and you'll be able to request all of those things in that survey. And we will also send out an email at the after this presentation. So keep an eye out for your inbox, and you will be able to access that survey for all these information and appointment requests there. So I'd like you to think about hearing loss just in closing. I realize I've gone a couple of minutes over. Just like you to think about hearing loss just like you would any other major illness, coronary heart disease, diabetes, cancer. There's no blanket cure for these chronic illnesses, but there are effective treatments, most of which are most effective when delivered early. So we know that hearing loss is a progressive degenerative disorder with neurologic involvement, and we just get our best results in the hearing clinic when we catch hearing loss early and we treat it early. So thank you all so much for your time and attention. I realize it's a busy time of year to join a session like this.